Hello again. I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. This is our 44th show, and this is the second segment of the quality issue in cardiovascular surgery. And I very much am enthusiastic about inviting our guest speakers to come back and discuss some further issues. You mentioned that there's a new technique now that is developed that can help performing coronary artery bypasses without the heart-lung machine.
Yes.
Maybe you can give us an idea.
The standard way in which coronary revascularization was done, which is called coronary artery bypass surgery, was to utilize what we call the heart-lung machine, where essentially you stop the heart and then this machine and this system supports the bodily functions. That's called cardiopulmonary bypass. And that has associated risk with it. And is very invasive approach.
Right.
In the third world countries, they developed a technique whereby they could do the coronary revascularization. In other words, make new vessels without using the heart-lung machine. And the way this developed is very interesting. They could not afford the cost of cardiopulmonary bypass.
That's fascinating.
So the choice was to develop this technique or allow these patients to go untreated. And as it turns out, they are able to do about 85% of the patients requiring coronary revascularization without the use of the heart-lung machine. Now the effect of that is it makes it less costly, shortens the hospital stay, and is certainly much easier on the patient.
Does it increase morbidity or mortality?
No, in fact, it decreases mortality and morbidity.
That's fascinating. You know, you see, that's again. I was interviewing a gentleman who has end-stage renal disease, renal failure, and he did not want to go into a dialysis. So he went through a extensive study of European diets and cooking methods that reduce the amount of, I guess, nitrogen, azotemia. And he did very well without very little dialysis. So in other words, I mean, that is very fascinating to me because there are ways. Technology is wonderful, but in countries where they can afford to have these technologies, they have other ways of going around and taking care of things in a very clever way. That's great. Let me read some excerpts of this article and see what you have to say about this. This is a challenge. Okay, this is an article which is recently published in the October 1995 issue of Family Practice Management. It was written by a Dr. Joanne Rosenfeld, who is a professor of family practice in Tennessee. It's called A Quest to Prolong Living, Not Dying. 2 weeks have passed since a mildly demented 75-year-old man with severe mobility-impairing Parkinson's disease suffered a myocardial infarction. His cardiologist presses him for a decision on coronary bypass surgery to treat the quote, curable, unquote, heart disease. The cardiac surgeon is willing to perform the surgery, but says the man has to decide immediately because putting off the surgery will increase his length of stay statistics. The man just wants to go home, and the family is ambivalent too. You and your group discussed the relative value of a major surgery and quote, cure, unquote, heart disease with the confused family and the patient who is depressed, lives alone, and is barely ambulatory. When you try to explain your concerns about all this to the cardiologist, he says condescendingly, "I'm just here to cure his heart disease. What you're talking about is philosophy." And then I still get the patients back when the specialists are through with them, when they have spent hundreds of thousands of dollars, poked instruments into every natural orifice, and several that they have made, created anemias from bloodletting, devastated families with hopes and failures, and finally used up their interventionist bag of tricks. I have spent most of my last 6 months in the hospital fighting to extricate my patients from the care of interventionist specialists. Do you feel attacked?
No, not necessarily. I think that whether you're a specialist or a internist or a general practitioner, which are non-specialists, but in fact are specialists, the failure often is that we end up treating disease and not the patient.
Right.
And even if you're a specialist, your obligation is to treat the patient, not just the disease that you were trained to address. And this is a situation where that decision should be made by the primary care physician in the family, not just the specialist. I mean, he can give you the relative risks of the procedure and the downsides and the upsides, but the real social decision has to be made by the family, the patient, and often with the primary care physician.
Right. I'm glad you say that, because again, you know, we are approaching an era whereby we are afraid that technology will take over, and we forget that we're here to treat the patients as whole human beings, and not just address him as a pathological specimen. And I think that point is well taken. Now, the other issue here for me is that this show was conceived really out of my desire as a way to communicate directly to the patients. Because as I mentioned, you know, if we don't reach out and talk to them in one form or another, they will ask somebody else. You know, I mean, a talk show host who may know very little about medicine, and that's very dangerous. And one of the issues that to me is very tricky, and I'd like to ask your opinions about, is that we are in a society where we focus a lot of attention on the issue of free choice, and medical care as a privilege, and I mean as a right. I'm sorry, as a right. I think that the situation in medicine is such that a lot of time it's not a question of free choice, but a question of free ride. I'm talking about people who want a lot of things because they don't have to pay for it. I was talking to a urologist who mentioned that a lot of time there's no indication for a prostate biopsy, but people wanted it because they don't have to pay for it. I mean, the cost is like $1,100, something like that sort, you know. And so that, in a sense, how do we go about utilizing all what we have, which are marvelous technology, the tools that we have, in such a way that is equitable? In other words, we utilize it in the right place and we don't use that inappropriately and either cause a runaway cost situation or increase morbidity. Well, is that too general a question? Or?
Well, it's not too general a question, but it's really never totally equitable. For example, the young man that comes in with a gunshot wound to the chest who's in a gang fight, he automatically goes to the top of the list of the persons in the hospital, so he gets care. But I think it's the same problem we're grappling with, not only in medicine, but in our whole social life in general in America, and that's that we have to come to grips that we don't have unlimited resources.
Right.
And what we have to decide is where do we spend the amount of money where it does the most good. But then you also have to kind of get lots of different opinions, and it's not just a doctor problem. As you recall in Oregon recently when they tried to rate the diseases, you know, 1 through 500,
right.
Everybody thinks that their disease is the most important thing. And I think if anything, our rush to make people pay for nothing is probably, to some extent, the wrong approach. They showed when they had people in the armed services or people going to clinics that if they only paid 50 cents, not a large amount to prohibit somebody from seeking medical care, that they decrease the number of visits by 25%. I think it's human nature, if we don't have to consider the cost, that we don't think about it. And I think one of the good things that's happened is we're starting to get patients more involved. You know, this is not just my doctor treating my disease, but we're in this with the patients. And I think we as a society will have to come to grips with that, and they have in other societies. And it won't necessarily just be age, but it's going to be many factors. In other words, recently tobacco companies have come under fire. You know, if you smoke for 40 years, 3 packs a day,
Right.
at what point do you maybe not get treated for certain things, or at least make the, for example, tobacco companies kick in part of the cost for that?
Right.
We have that with children, you know. You mentioned that on previously about premature babies. I think it's a very difficult situation, but I think it's something we as a society, not just in medicine but other areas, will have to eventually come to grips with.
Yeah.
And we've been fortunate in this country because we've had such unlimited resources that we often haven't had to deal with that before.
But we're running out of them, though. I mean, we are spending 14% of our GDP, and if we continue to do things the way we do now, in another 30 years, we'll be spending 1/3 of our GDP in medical care. And I think that that's really a dangerous trend, because like I mentioned a lot of the issue of accountability. In other words, like you say, you know, a person can have a very destructive kind of behavior, and for a very long time, and we don't go about helping him to change his behavior. But you offer technology as a quick fix. So they say that I smoked for 40 years, but I can always expect to have a 3 hours coronary bypass, and I can live another 50 years. And to me, that sends the wrong message, because technology has to be used appropriately and judiciously.
Well, I think we're finding the way to do it is education, and not so much maybe punitiveness. For example, in some countries, they're basically saying, if you don't lose weight and don't stop smoking, we won't operate on you. I think in America we might have a little difficulty with that, because he'll turn around and say, well, if you're not going to treat me, are you going to treat the guy with hepatitis from his drug use? You know, and so I think that we found that the American public does respond very well, though, to education. As we mentioned, the problem, for example, with smoking, I think people become more aware about diet, exercise, and I think especially if we target, say, younger people, teenagers, young adults, getting children, you know, into these habits, then I think we can see some change. Unfortunately, problem with those type of changes, they don't come overnight. They take many years, and sometimes we as a society are a little bit impatient. And so we have to realize we have to invest in that for the future, like you say, to avoid consuming all of our gross national product and nothing but treating disease.
Yeah. You know, I'm not a cynic, but I'm just raising this picture and see how you think about it. You have Philip Morris, you have Seagram's and Budweiser, and you have McDonald, and you have the Cardio-Vascular Institute. And I think it's just, you know, I think they belong to the same problem. I think that, you know, I mean, I personally believe that, you know, if we deal with the causes of the problem, we have to say, I mean, like there's an internist by the name of Dr. Alan Blum from Houston. He stands up and says that we have to switch the focus not toward telling people to stop smoking, but attack the cigarettes industries, because they, you know, they make enormous profits. I mean, one pack of cigarettes is like 4 cents worth of to manufacture, and they sell for $2. And they really carry a tremendous power in our society. And those people don't smoke probably. You know, I mean, it's just like, I don't know. I mean, this is very strange to me, because they have a lot of power. They create a lot of harm. And if we feel that if we at the receiving end, where the patient has coronary arteries, and we fix them, maybe we are part of the problem.
Well, that's like Tom said, that gets to be very philosophical and socialistic, because by the same token, what would you do? Would you start taxing people who sell crack cocaine? Or McDonald's, there was some information recently that fast food may help contribute to your atherosclerosis, but it may also prevent cancer. I think that you can obviously get some of the monies from them, like we did recently with the California tax, to try mainly to direct it toward teenagers. Nobody ever starts smoking at age 40. You know, nobody comes in and starts drinking generally at age 45. And so if we can educate the younger people to avoid these things. But I think prohibition, as we found, did not work well. And do you really want an underground market in cigarettes like we have in drugs now? So I think you can't sometimes just come down, you know, in a black and white way with these sort of things. I think, like I said, I think education is the main thing, and the number of people that smoke do go down. And I think you can tax them to some extent, but you know, where does it stop? Do you get General Motors for everybody who gets killed? I mean, you know, in a car accident, you know, it's a very kind of touchy issue.
I believe that we have to ask the questions why people smoke and why people drink. And I think that This is the product of a society that is probably very competitive, very aggressive. People do those things to escape. And I think that we have to address those issues very as aggressively as taking care of the end product. I sincerely believe that, because education is one thing, but I think until people are accountable for their actions, I mean, their behavior is going to change.
But I think those are habits that we actually have found that people pick up when they're too young to worry about stress. Most people start smoking cigarettes before they're 17 years old. Like I say, you rarely find somebody who says, you know, at 43, well, you know, come home and say, look, dear, I found this new thing. You want to try one of these Pall Malls? That's not the way it works. And the same thing with drinking. Part of our problem is we depict certain lifestyles as very attractive to young people. If you look at the movies, for example, even though we're very much anti-smoking, every character in most of the movies aimed toward the teenagers and 20-year-olds smokes after sex. So it hasn't changed since we saw Bette Davis. They all drink because it's a cool thing to do. And on TV and soap operas, they all have sex, but they never get pregnant, they never get AIDS, they never get sexually transmitted disease. And I think the problem is we as parents, educators, and healthcare individuals and providers have to start stressing that to them, because they're not under tons of stress at age 17. People smoke because it looks cool. The slim girl in the magazine cover, because I address a lot of women about this, she's slender, models. Every time you see Naomi Campbell, she tells you she doesn't eat anything, but she smokes 2 packs a day. Well, the young girl looks at her and she says, I want to look like that. She gets the good-looking guys. That's when she starts smoking. It's not when she's 30 and she has 5 kids at home and she's under stress. And the problem with those kind of habits, we know when you start young, they tend to become a way of life. And so I think that's where we kind of have a dichotomy. We tell kids one thing, but we show them something else. And I think we really have to, as adults, start looking at what we're showing our young people. And like you said,
I agree with that wholeheartedly, because I believe that, again, you know, I mean, we talk about, to me, it's not philosophy, because that's part of our job, is to take part in the preventative aspect of different diseases. And like you say, I believe in a process called role modeling. You know, people are born in America and they look up to certain successful people, be it in the movies or in the fast track kind of living. I think that's very unhealthy. And hopefully we can play a part in saying that maybe you should look at things more realistically. I guess one of the political agenda now is going back to the family values, what have you. I came from a different environment, and I think that there are things that eventually somehow will affect our health because of the attitude that we create for ourselves. I personally never got into any of that, drug or alcohol or cigarettes, because I felt very strongly that there are other things I can do to derive pleasure from. And to me, one of the things that I don't think that I would like to go too much into the philosophical aspect of it, but to me, one thing that is lacking in our society in America is that I think that the human warmth is sometimes very lacking in our workplace and our family life. And like, you know, this morning I have attended several meetings of the AA, and people do that because they couldn't cope with the pressures around them, and they want to escape from all the hustle bustles of life, and they get into habits, and we come here, you know, we're here to receive them when they are really totally in a wreck, and you try to fix them, be it, you know, gang violence or domestic violence or drug abuse, alcohol abuse, cigarette smoking. To me, all those things are social, cultural, and not purely medical phenomena. And I think that would be, we'll miss out something if we just approach the medical end of it. We can look into the microscope and, you know, diagnose cancers and try to treat them with chemotherapy and surgery and radiation, but it is known that up to 70–75% of causes of cancer are preventable through a certain type of diet or certain type of, you know, lifestyle. So I mean, talking about the 2 major diseases in our country, cardiovascular diseases, hypertension, and cancers. And most of the factors are preventable. And what are we doing about it?
Well, I think part of what the American public has to come to recognize, not only recognize but respond to, is that the individual ultimately is responsible for their own well-being.
Okay.
And even having said that, it's quite obvious that we still persist in some environments in allowing extreme violence to occur where it is clearly known that serious bodily harm will occur. And yet, for some reason, they don't remove themselves from those environments.
Mm-hmm.
I think as Sharon is saying, you know, this is a matter of education. This is a matter of changing some basic perspectives on life.
Mm-hmm.
And I think it does get back to family values and the importance of the family unit,
Mm-hmm.
which you know is missing in many areas of the United States, and it's geographically it seems to affect everyone everywhere.
Mm-hmm.
And I think you made a good point when you talk about a different culture, because I think one thing that people are emphasizing, it maybe in America we're a little bit too much individualistic, and sometimes we don't put the good of the group a little bit ahead of individuals. For example, they're trying to repeal the helmet law in Sacramento.
Right.
But we all know that the number of people who've had serious head injuries, become quadriplegic with the helmets off is astronomical.
Mm-hmm.
But somebody wants to feel the wind blowing in his hair on his motorcycle.
Right.
But then when he winds up in the hospital, 90% of the time he has no insurance.
Mm-hmm.
Even if he does, it's a tragedy for him and his family.
Mm-hmm.
And then the public is made to pay for this.
Yes.
So where do you kind of balance the individual freedom versus the good of society? And like Tom said, we sometimes, I think, have been so strong with that individualistic problem. But if you go back in our society when we didn't have social nets, you could go and do anything you wanted in your farm down the road, because if you didn't have food for the winter, it was your problem.
Yeah.
Now you bring the rest of us in because I'm forced to pay taxes when you don't do certain things.
Yeah.
So like you say, it becomes a real difficult problem. And I think we eventually going to have to probably do more of that of, like you said, what's good for the family and the whole unit,
Right.
and not just what's good or not even good for me, but what feels good. Because those kind of things are the real problem.
Yeah. You see, the other extreme is like the Japanese society. They are very strongly identifiable with the group or the community, and sometimes at the expense of their individualistic rights, and I think that's the other extreme. But look at the situation at Kobe. 1 year after the tremendous destruction by that earthquake, they're back on their track, because they have a sense of community and a sense of responsibility toward others. I admire that. I think maybe you can learn some of that, because I think that, as you say, I mean, especially, California dreaming is really the land of the individuals who think too much of himself without having any kind of sense of responsibility toward his own family, even, or his community. And I think that I don't think it's out of our place to say those things, because I believe very strongly that as physicians we have to take some form of leadership role in a community, instead of just being the technician doing the operation or prescribing the pills or whatever. Because I think all those issues are more social, cultural, and economic than purely medical.
There was a famous medical quote that it's important not to treat the disease and the patient, but the patient with the disease.
Yeah.
And I think it's been shown that when physicians mention to patients or ask questions about certain things like their health habits and their family, it does convey to them the sense that these are important things.
Yeah.
And I think too often, like you say, we sometimes focus too much on the technology as opposed to also speaking with the patient about other things going on in their life. And I think they appreciate that. And I think we can work together more so than this sort of doctor, that's
Absolutely,
big brother.
absolutely. I cannot agree with you more, because I am very concerned about the fact that the delivery of medical care is more and more under the domination and the control of business people. And like in primary care, we see 50, 60 patients a day, and we just don't have the right kind of time to spend quality time with the patients and go into the aspects of prevention and education. And very quickly, you know, if we do anything, if we do something, then we're compensated for what we do. And if we try to explain certain things, I mean, you know, many different issues. I'm very pleased that you are so aware of all those aspects of medicine, because obviously, to me, that is very encouraging, because you're not just like, you know, this article obviously was mentioning some of those, and I'm very pleased that you are refuting that notion. Anyway, we have been talking even more philosophy, which is a pleasant surprise for me. And I actually, in a sense, I expected that, you know, when I read their bios and their CVs, I was very impressed by the fact that they are not technologists, interventionists, but they are very excellent human beings and humanistic, have a humanistic approach in their care. Anyway, I'm Dr. Vu. We just finished the second segment of the quality issue in cardiovascular surgery, and I'm very grateful to have the opportunity to interview our excellent surgeons, physicians, and teachers who are here to have shared with us so much about the global aspect of medical care. And again, I'd like to thank you for watching our show, and I hope that you enjoy it, and so long. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one, now that I am here.